I was 2 years old when I found out I had a brain tumour, and since then it's been all go, still in the stupid brain of mine, fighting it like I always do. And just a couple of months ago, I had a massive bleed to the brain unexpectedly, and that led me to where I am now, just paralysed, just a bit of everything really, learning to walk again in physio, and just, it's crazy, demented in here, and just hoping I get out soon.
The conditions we deal with are very, very serious. They're often life-threatening, and in terms of the treatment strategies that I'll utilise for different surgical manoeuvres, they would be high-risk strategies. They're not small procedures, but you're weighing that against the gravity of very serious disease processes that are inevitably or can be life-threatening in a lot of these patients.
It all started in the morning. I was packing my bag a week early to go to school, went to brush my hair, put the brush to my head, massive pain in the brain. I was covering my eye because my tumour's on the right hand side of my head. I screamed for my life, and it was a massive shock. I've never had the pain in my life.
Dealing with brains and spines, they are very eloquent structures. They're very important structures, and the margin of error or the room for error is not there. I can't go into normal brain without causing some potential severe, life-threatening or permanently disabling impairment to a child.
We got rushed up to our wee cottage hospital. It's the smallest hospital you've ever been in, and then we went to hospital, waited for like 25 minutes. Mum had to go up, pack the suitcase when I was feeling better. Had an ice pack on my head. The helicopter came all the way from Prestwick, and then it was landing on our small airport, flown to Glasgow, landed in the airport. By that time it was rush hour, about 5 o'clock, 5:30ish, and we had flashing blue lights all the way to here.
The equipment we're looking at is in the field of neuroendoscopy, and in one sense that provides a minimally invasive type of approach to get into the brain, principally into the fluid cavities that we all have in our brains. And that's where we can find pathology, buildup of fluid in that cavity, hydrocephalus, we can aim to treat. Conventionally, the condition's treated by a piece of foreign material we put in the tubing to divert the fluid of the brain. That's called a shunt, and it's one of the most common operations I perform. Unfortunately, since the advent of shunt in the 1950s, nothing has really changed. The technology has not advanced shunts. They still have a failure rate of 40% at 1 year, 50% at 2 years, 70% at 4 years. What I'm saying in essence is if I put a shunt in your child, in the first year, 40% of them will come back to have a piece of the equipment changed because it'll have malfunctioned. And so often people forget that when you cite a shunt, it's akin to giving a long-term condition to a child. I would often say to parents, it's no different than me giving your child diabetes in one sense. Once you have a shunt, you tend to have it for life. The endoscope may create bypassing in the fluid waters and avoid a shunt. And altogether, better situation immediately and certainly in the long-term management of these children.
The care I get in here is really, really special to me, and that's why we're asking for the endoscope. Jennifer Brown, Roddy, anyone who wants that bit of equipment should get it, because it might be one day they might need it unexpectedly and they can't just do it by hand. So it's a real honour, and the nurses in Schiehallion, up here in 3A, are all special in their own way, really amazing. No words to explain it, just amazing, outstanding.
There's an evolution going on here, and we've got to evolve in what we can do. And I certainly want to take this field, and I want Glasgow to lead in this field.
Got the results, my tumour's going smaller, but for people who's been on it for years as well, you just can't give up. I feel like that every day, so just don't give up. That's what I say.